Now I'll turn it over to Chris and Dr. McKenzie to begin the Q&A session.
We'll begin with Dr. McKenzie. There was a question referencing an article. The article is Fracking and Infant Mortality, Fresh Evidence from Oklahoma. And this participant wanted to know, it said it was not mentioned in regard to Oklahoma. Does anyone know anything about this study, or do you know anything about this study? Anybody on the panel?
So I was not aware of that study, but I did just look it up. And so I can read to you the findings from that study, or just summarize them. So what they found in the study, that was the closer the mother's residence was at birth to the fracking wells, or number of wells around the residence, the more negative were the effects on the infant's health at birth. And so that included mortality and some other measures of the infant's health.
Okay. These questions will be going to Mr. Gonzalez. There was a question about African American women who are more likely to have twins than any other race, and more likely to have low birth weight. But you had already answered the question in the chat for this person, and you said that there was no twins in this study. So thank you for answering that.
Yeah, and I should have added, so we had our data were linked to hospital admissions data. So that allowed us to do a lot of controls that I should have mentioned in the presentation. So that means we were only restricting to singleton births, because we know that birth or preterm birth changes for when there's more than one infant being delivered. And we also we excluded women with comorbidities that also increased risk of preterm birth. So we excluded if they had hypertension, gestational hypertension, eclampsia, preeclampsia, or a medically indicated preterm birth. So a preterm birth that was induced medically. So what we're actually focusing on, and apologies I didn't make this clear, is spontaneous preterm births without any other known medical explanation. These are the cohort of preterm births that we just as a field are trying to understand what's causing these preterm births. And our evidence and many other studies find evidence that environmental exposures may be part of that risk profile.
Okay, well, thank you for clearing that up. And the next question for you would be, what is the lifetime of those Bakerfield's wells? And are they fracked with large quantities of water and sand like Pennsylvania shale wells?
Yeah, in terms of the lifetime, I don't know precisely. It's in the data. The data is publicly available from CalGEM. My impression from working with the data for several years now is that some of these wells have been operating for decades, active for decades, and there's a pretty constant volume of production. Millions of barrels of oil and gas produced in California each month, between 1 and 2 million, and hundreds of wells are drilled each month in California. And as I mentioned, some of these wells have been operating for a very long time. The other question was about hydraulic fracturing. Most of the wells are not hydraulically fractured in California. There are some hydraulic fracturing wells happening in some parts of the state, in some parts of the San Joaquin Valley, and in the Santa Maria Valley, which is actually where I grew up. There's hydraulic fracturing there as well. But these are pretty constrained. And I saw that so we actually didn't differentiate, and I think this will get at another question that was in the chat. We didn't differentiate between hydraulically fractured and unfractured wells. The data were not publicly available from the state, at least in the form that we could find. And we were interested in just seeing if we can see a signal for exposure to oil and gas wells in general.
Do you want to mention that? So what was the other question that you were mentioning, if you want to go ahead and answer? This question just came in and said, wouldn't results be somewhat skewed, diminished by combining conventional and unconventional drilling, since fracking produces more air pollution, leaks, etc.?
So this is a question about exposure classification. So if we're saying that exposure to conventional wells we're assuming that it's equal to exposure to unconventional wells. the way that we set up this particular study. If more risk is conferred by unconventional wells, and we're saying that it's equal, I would expect that would bias us towards a null. So we're saying you're exposed to wells. I'd probably need to sit with this for a little bit longer to come up with a more coherent answer, but my impression would be that the fact that we're seeing a signal suggests that conventional wells do confer risk. If we were able to differentiate the effect of conventional and unconventional wells, we may hypothesize that we'd see a stronger association with exposure to unconventional wells, if it's true that they confer more risk. But we have evidence that both types of wells, or at least in aggregate, that both types of wells at least are producing PM2.5. It appears in our data.
I'm going to chime in on that for a second here. I also think there's some work that Seth Shonkoff has done that has shown that it might not necessarily be true that more risk is conferred by unconventional wells than conventional wells.
I'd also like to add to that. So I'm actually working on publishing a study related to exposure to oil and gas, or unconventional oil and gas in California. So to provide you a bit of context in terms of the background. So as we both mentioned, that fracking does not contribute a large proportion to the overall oil and gas development in California. So that's one point. Secondly, is that because of the geological formations here, the length of actual fracking is about 1 day, maybe 2 days at most. So it's quite different from how it occurs in other states. So for that reason, it is a challenge to differentiate between exposures exclusive to fracking versus conventional oil and gas developments. And both conventional and unconventional oil and gas development have air pollution coming from equipment that is used in operation, like regardless of whether you have fracking or not. And also wastewater is produced and it requires disposal, again, whether you have fracking or not. And in fact, there is a larger amount of wastewater produced from like just oil production in general, regardless, again, of whether you have fracking or not. So it is really challenging in the California context, to sift that out. And the amount of water that's used in California is proportionally much smaller compared to other states. So I think, California is kind of in a very unique position when we're thinking about fracking and conventional wells. And so for that reason, I also looked at both exposure to conventional and unconventional oil and gas wells.
Oh, great. Thank you. Thank you for that clarification, Dr. Tran. We have a few more questions for David, and then we'll move on to Dr. Tran's questions. So David, how were controls selected, and what was the case control ratio? This is a two-part question. And also, what was the basis for the selection of the period time? And because the measurement period ended in 2011, were the wells predominantly conventional?
Right. Well, for that last question, the wells have historically been predominantly conventional in California. So
yeah.
Just to answer that, how do we select cases, controls for the cases? It was a random selection, so there wasn't a matching procedure. We selected random. So after making our exclusions, as I mentioned earlier, so excluding births that has some other sort of preterm births that has some other sort of medical explanation, we did a random selection, and I believe a 3-to-1 ratio of term controls to preterm cases. And forgive me, was there another question in there that I haven't answered?
No, I believe that was a question. Yeah, you answered it. Great. So the next one is, has there been any consideration to examine cord blood for evidence of toxins related to the shale gas industry?
Well, if that's a question for me, it's something that I think would be interesting. It's outside the scope of a PhD candidate to do that sort of campaign. But I think it would be it would add, if we were able to do that sort of study, it would add evidence to validate our exposure metric.
Um,
Go ahead.
So I'm not aware of any studies that have done that yet. It is an interesting question. There are some things that one would need to think about when looking at cord blood. For example, if you were looking at a benzene exposure in cord blood, just remembering the very short lifetime of benzene in the blood, and if the effect was in the second trimester, or the first trimester, if the exposure and the benzene exposure was then, you very well would not see that in the cord blood at birth. It's not going to stick around that long. So you'd need to really select carefully what you were looking at in the cord blood and think about what it means for the time between exposure and health outcome.
All right, thank you. And David, do you consider stratifying by type of well, those that use directional drilling combined with hydraulic fracturing versus conventional wells?
We did not consider that for the previous study. I'm doing some work right now. We can look, we have not been differentiating in that regard.
Okay. And why did you choose a 10-kilometer buffer radius?
It is an arbitrary radius. We did it for several reasons, partly because prior studies have used 10 kilometers to define their radius. So we want to make it easier to compare our study with other studies. Just to note, because of our inverse distance squared weighting schema, a well at 10 kilometers would contribute very little to that index. We did sensitivity analyses, so we did additional analyses where we varied the distance. We looked at exposure to wells within 15 kilometers, 5 kilometers, and 3 kilometers. That did not substantially change our results, except for at 3 kilometers, we saw a diminished result, but that could be partially due to the fact that we have very few births that are exposed within 3 kilometers, and wells beyond 3 kilometers, as we have evidence for, may contribute some pollution.
Okay. And there's one more question here specifically for your study. In the risk chart, there was increased risk for Black and Latinos, but you noted that they were inherently at risk. So was that adjusted for in the chart?
I want to make sure I fully understand this question. There's nothing inherent about being Latinx or Black. There's nothing biological about that. They are socialized, racialized categories. So we differentiate because there may be effects of exposure to structural racism experienced by Black and Latinx women, not experienced by non-Hispanic white women. When we do our stratified analyses, we're trying to get at those differences in risk profiles. So we think if we're only looking at women that also have exposure to structural racism and we still see an effect of this exposure, we saw that, but we didn't see it for non-Hispanic white women. So it suggests that there may be some sort of interaction with structural racism. We're looking more into that in follow-up work right now. So if I didn't answer that question, let me know. I'd be happy to take that question offline or provide further follow-up.
Okay, well, the person who asked that question can privately message you in the chat, but I think you clarified it pretty well. And let me see. So we'll move on with Dr. Tran, and these are specifically to her. Whoops, there's one more for David. Okay. One more for David, then we'll move on to Dr. Tran's study. And if anybody on the panel, the panelists do want to contribute to the answer of the conversation, just please chime in anytime you like. So Mr. Gonzalez, is there sufficient well water data to determine whether the affected population is primarily exposed through air or water pollution or both?
I'm not familiar with well water data, so I'm not really able to comment on that. I did see that Janice added some clarification that there is increased risk of preterm birth, reduced just a preterm birth for Black women. That is true. We don't know why that is an active area of research. So that is why we did that stratification. In terms of well water, I don't know. I have some colleagues that are working on this issue in California that I could direct you to.
Would anybody else on the panel be able to give some insight into that question?
Sure, I can. So
Great.
this was part of my third chapter of my dissertation. So just a little bit about the context. So there actually isn't easily accessible well water data, and in California that's publicly available. And I'm sure there are people that are working on it, but there is studies published by USGS, and based on what I've seen, it's really challenging to connect particular like contaminants such as benzene coming directly from oil and gas development that's found in the water and connect that directly to oil and gas development. That connection is really hard to make, but they also, in some of their studies, they also mentioned that essentially the movement of water can also potentially dilute the amount of contaminants, like the concentration of the contaminants. So potentially, even if it is ingested, again, it's very hard to decipher whether that would then lead to a particular health outcome.
Thank you. And we have a few questions for you regarding your study. And this question states, you mentioned many wells are oil rather than gas in California, and we talked about that. Do you see the same levels of flaring that were referred to in Texas by speakers yesterday? California oil and gas wells are mostly conventional vertical, but are these vertical wells shale wells, and i.e. are they fracked? And I think you alluded to some of that earlier.
Yeah, so so I don't know what the statistics in terms of flaring, like how frequently that occurs in California. But what I do know is that sometimes at particular oil and gas fields, there is a mixture of both oil and gas. So for that reason, in order to separate it, they do need to burn off the gas. So I'm sure there are occurrences of flaring, although I can't speak to how frequent or prevalent that is.
Okay, thank you.
I can briefly comment on that. I know that there's substantially less flaring in California than in places like the Eagle Ford Shale in Western Texas. So there is some flaring, substantially less in other settings.
Okay, thank you. And Dr. Tran, how are you able to get data and production statistics from the oil and gas companies?
Yeah, so the oil and gas companies have to report how much they're producing to the state, and I think this is on a monthly basis. I don't know if it's any more. I don't think it's daily because I collected the monthly concentration or production volume. So the state has California Department of Conservation does publish the monthly production, so that is publicly available. Although you do have to get into the databases in order to access that information.
Okay, thank you. How do you normalize production volumes between gas and oil wells since production metrics are different?
Yeah, so I converted the units. So I believe the units is in cubic centimeter or cubic meter for gas. And so the way that I made that conversion is that I divided it, the value of the gas production by 6. And this is a methodology that I found online that is done by oil and gas companies, I believe. And so that's how I converted the units to barrels of oil. and then I sum that amount to the total oil production.
Okay, thank you. And is the difference in response between rural and urban populations because urban has exposure from other sources? In controls with no exposure, is there a rural-urban difference?
Okay, so to the first question, so I know that every region has a mixture of various sources of contributors to local air pollution. For example, in maybe the San Joaquin Valley, a large contributor is the agriculture industry, whereas in more urban settings, traffic pollution is a huge contributor to the overall air pollution. And so I didn't integrate any air pollution sources into the analysis. However, I did adjust for traffic, which is, so nitrogen dioxide is proxy for traffic pollution. And then in a sensitivity analysis that I briefly mentioned during the presentation, that I did was that I looked at highly polluting industries and where these facilities are located. So I adjusted for that in the model, in that if there were any highly polluting facilities within a particular census tract, then that was a proxy for whether or not there were other sources of air pollution in the area. So that's how I adjusted for that in the model. And then the effect estimates were similar regardless of whether I included that or excluded that particular variable. Now, to the second question, if I'm understanding that correctly, so I think maybe I didn't explain this carefully, but so what I'm comparing, when we're looking at exposure to production volume, what I showed there was exposure that was at the moderate level of production volume and high production volume. And the comparison group, or the control, is the unexposed. So that is the same for both people who are exposed to a moderate level versus a high production volume. So the comparison here, what we're comparing is, what we saw is, for example, in the low birth weight example, there was approximately 40% increase in low birth weight for people who were exposed to high production volume compared to those who were unexposed. And I can further clarify if you have additional questions.
Okay, thank you. And you alluded to some of this in your response, this question, and this is going out to any of the panelists today. Why do these studies only look at proximity to oil and gas wells and not other sources of pollution like compressor stations, pipeline, pigging operations, processing facilities and refineries, landfills, injection wells, etc.? And that can go out to any or all of the panelists.
You go ahead.
Okay. So my answer to that would be, so the first studies, or the studies just looking at proximity haven't done that, but studies are beginning to look at that. So the second study we did on congenital heart defects, we actually did look at proximity to other major sources of air pollution, and included things like power plants, other types of oil and gas sites, so refineries, included centralized animal feeding operations, and a number of other large sources of pollution. However, what is going to be more difficult in these studies is to look at the many small sources of air pollution. We'll have to think about how to do that. So things like gasoline stations, for example. And so small sources of air pollution, particularly in urban areas, is things that are difficult to account for.
And this is our final question from the chat, and it goes to each of the presenters. Are there any points from your presentation that you would select to be communicated to partners for health, well-being, and safety at the home fronts that are impacted by the various stages of the shale gas industry? So whoever would like to go first on that.
Sure, I can go first. I think one of the criticisms I've heard is that we don't have causal evidence that there is an effect of exposure to proximity to wells on risk of these adverse birth outcomes. Similarly, there's no causal evidence that proximity is safe. And we have associational evidence that, so we are finding evidence that living in proximity to oil and gas wells confers risk of preterm birth. These exposures have been happening for decades. They disproportionately impact communities of color. And I think that there are some policies, especially in the California context, that would be very reasonable. There's no statewide setback policy. Some local jurisdictions have setbacks. Many other states, states far more conservative than California, such as West Virginia, have like 1,000-foot setback between wells and homes, while California still does not have one. So I think I think that this is an evidence-based policy intervention that could provide some level of protection for communities. Secondly, we find evidence. I think the other finding that we have that is relevant is in some ways verifying our proximity metric, that we are finding that proximity to oil and gas wells is associated with higher concentrations of PM 2.5, which is a potential mediator for the effect of proximity on adverse birth outcomes and many other potential adverse health effects.
Thank you. Dr. Tran?
Yes, thank you. So I think a major takeaway from my analysis is that my study suggests that there are potential risks related to people who live within proximity to oil and gas development. So, to reemphasize what David has already mentioned, I think it's very important for regulators to take public health into account as they are making their decisions, as there are potential risks there.
Thank you. And Dr. McKenzie, if you'd like to answer
yeah,
that.
so I would like to add to that, and I think both of the setback is both Dr. Tran's and David's comments on the setback distances were appropriate. I also think the other one that we have ample evidence to support now is controlling emissions from the oil and gas sites, air emissions, to the extent possible. And this goes to, when we look at proximity, we're talking about things like particulate matter and hazardous air pollutants. However, these emissions also contribute to regional ozone, which can affect everyone in the region. So a setback distance isn't necessarily going to protect people from ground level ozone that this industry is contributing to. It's not the only contributor, but it's a major contributor. So I really think that attention on to controlling emissions from oil and gas sites, both from diesel engines and equipment and direct emissions from the well sites, is warranted.
Yeah, absolutely. And we have a few minutes left, and I'd like to turn it back to Dr. McKenzie if you have any further questions for the panelists, or if you have any remarks to wrap up our session here.
I think I'd like to wrap up by asking the panelists and just to kind of have a discussion. You've alluded to this a little bit and what else you're looking at, but what are we thinking about for future studies? So what other birth outcomes and early life outcomes should we maybe be focusing on around these sites? And then what should the future study designs look like? So there's been a lot of retrospective studies using this proximity metric. How can we improve upon that? Or is there another study design that might be add to this evidence base?
Well, in terms of other outcomes, I think you alluded to this. For the reasons we study birth outcomes, one of the reasons is we have residential addresses, which allows us to estimate exposures at the home. We don't have that kind of data, that kind of spatially resolved data for a lot of other health outcomes, which is part of the motivation for me to look at concentrations of air pollutants. We have a well-established literature for how the effect of PM2.5 on health. In terms of other birth outcomes, there have been studies in other states, I believe, looking at birth defects. So I think that's something that we're interested in. I think you've done some of that work, Dr. McKenzie. So maybe replicating that work in California, given that we have, an exposed population, we have the data. In terms of methods, one thing that we're working on right now, so maybe this is a bit biased for me to say, is using a sibling control. So we have data on we can match siblings to one another. We can control for factors that don't change within the mother from one birth to the other. That should take care of a lot of the residual confounding, so unexplained potential factors that affect preterm birth. That's a study design that I think can be applied in this setting, and I think can build on the base of evidence that already exists. Yeah, I think that's where I'm at with that right now. Partially because I'm deep in the weeds of doing that analysis.
Yeah. Dr. Tran, did you have anything you wanted to?
Yeah. So I'm working to publish my analysis related to exposure to fracking specifically. So the study design is very similar to what I've presented here, with the addition of a variable for specifically for fracking. And I do want to note that, again, it's really challenging even for my own analysis to differentiate between fracking and conventional wells due to the limited number of fracked wells, but also just due to the nature for the fact that it's wells are fracked within approximately a day. So it's very hard to capture whether or not the effect we're observing is really specific to fracking. And secondly, is something that I thought a lot about when I was conducting these analyses, is that I think it would be really helpful if there were publicly available information on perhaps violations from these oil and gas sites, because for example, if we wanted to better understand whether or not a particular area is highly polluted due to oil and gas development, or in terms of air pollution or water pollution, it would be easier to collect samples from a particular site, because it is very expensive to conduct these types of analyses to collect data. Then it would be easier if we can understand perhaps an area where there are maybe a history of violations and how severe those violations are, and analyze that data to understand where we can direct the monitoring efforts.
Okay, and I'm seeing a note that we need to wrap up here. So I would just thank both the presenters for I think that what you've done is interesting and really adds to the evidence on this. And that would be my concluding remark, just to wrap it up.